This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome to the Neurology podcast. I'm Jessica Ailani, Director of the Georgetown Headache Center and Professor of Clinical Neurology at MedStar Georgetown University Hospital in Washington, D.C. In this session, we will be discussing the International Headache Society's global practice recommendations for the acute and preventive treatment of migraine. We have with us one of the authors, Francesca Puledda, a neurologist from King's College in London. Francesca, welcome.
Hi, it's a pleasure to be on the podcast. Thank you.
So how did these practice recommendations come about?
Well, the idea behind these recommendations was really to create a practical set of clinical scenarios for the pharmacological management of migraine and to offer a clear evidence-based guidance for treating this condition. But to make the recommendations truly global, since we're an international society, we really had to take into account the large differences that we know exist in medication availability worldwide, not just between countries, but even, for example, within middle and high income countries. So, for example, we have these really incredible new drugs that target migraine mechanisms specifically, but these are not necessarily available for all patients in the world. So, we decided to structure our recommendations into two levels, optimal and essential. And the optimal level really reflects the best available practice, the one we all have to strive for, while the essential level provides a viable alternative that is mostly based on expert opinion and not necessarily on hard evidence because it's not always available. So this dual approach really ensures that our guidelines can be applied more broadly, and we think it makes them accessible to a much larger number of healthcare providers and to patients worldwide.
I really love this idea of optimal, what we strive for, and what can be done, because I think many times, regardless of where you practice, this is the day-to-day of what we face. And a guideline like this can really be used by a specialist, a general neurologist, your primary care practitioner. So I'm really excited to get into this. So we're going to start with, I think, the most essential. We're going to start by talking about acute pharmacological treatment recommendations for migraine. So here we have 17 questions that are addressed, everything from where a person with migraine should start treatment to migraine in pregnancy, menstrual migraine, and migraine in the age above 65. What are some basic recommendations for someone who's never seen a clinician and has migraine?
I just want to say that it might seem like these documents are really daunting, but I want to stress that they are a very practical set of recommendations, that they're really accessible for everyone. So to answer your question, for a patient that has never seen a doctor for migraine, and really let's pause and reflect on the fact that that's the vast majority of the 1 billion people that are affected by migraine in the world. So we wanted to really keep the threshold for starting a migraine-specific acute treatment quite low. So that's why we recommend using a triptan for anyone with migraine who doesn't have a specific contraindication for it and who isn't responding to analgesics or to NSAIDs. And actually, by not responding, we mean someone who isn't completely pain-free 2 hours after taking the medication. So this might seem like quite a high bar because it's the same criterion that we would use in the randomized controlled trials to measure efficacy. And of course, we know that in real life, this isn't necessarily an achievable outcome. But the key idea here is that there's no strong reason why a well-known, generally safe drug like a triptan shouldn't be used as soon as possible if it's appropriate.
I actually love this idea. The fact that we should go to specific migraine treatment early is very important. And so my next question is, what if someone has tried something simple or a combination analgesic? So in the United States, these are simple things we can find over the counter. And a patient like this, these are most of the people that are going to be starting out in general neurology clinic or in primary care. They've already tried something simple and they come in to see you. What are you going to tell them to try? Say they have no medical contraindications.
So assuming that they don't have any contraindications and they've tried standard analgesics without success, the step is to move on to a triptan. Some recommendations for triptan use, they should be taken as early as possible at the start of the attack, and we go through these practice guidelines in the documents. But they shouldn't be taken, if possible, during the aura phase, because there is evidence that suggests that triptans are less effective when taken during the aura. So if an aura is happening, the patient should ideally wait for it to stop. If it's a very prolonged aura and the pain starts during the aura itself, then the triptan should be taken when the pain starts, but not when just the aura is present. And we don't specify a particular triptan to start with. We know that there's 7 available options, but we do highlight some meaningful differences among the triptans. So these are very small differences, but they can be meaningful at an individual level. So for example, sumatriptan is the most extensively studied, so it can serve as a baseline choice. And then you have, for example, rizatriptan and elatriptan that tend to be more effective, while naratriptan or frovatriptan are better tolerated generally and have longer half-lives, so they could have a reduced risk of relapse within the same attack. It's also important to remember that triptans, some of them come in different doses and routes of administration, so if one doesn't work, the patient and we can consider trying a different route or a higher dose. And if a triptan fails in 2 out of 3 attacks, then we can switch to another triptan up to a maximum of 3 different options. And after that, it's really time to consider a different class of medication.
So one of the great things I love about this article, not only is it written out in a question manner, so it's like, here's a question, here's the answer, but what you just discussed, that's like what we spend the first 3 months of headache fellowship training in, is really getting to the bottom of understanding how the triptans can be effective in different ways to patients, how one triptan might not be the same as another on an individual level, understanding different routes of administration and how impactful that is in migraine care. You know, and just because someone didn't do well with an oral triptan doesn't mean a nasal might not work. And that applies past triptans, but definitely something that we stress. And I think it takes a few months for our fellows to really get comfortable with that concept. And so amazing. You know, reading up to question number 4, you're already getting a hang of this is what we're thinking about as headache specialists. So let's keep going. There's so much more important stuff to learn. So let's talk about something I get asked all the time when I'm teaching on migraine. And that's, what do we do for a woman who's pregnant, who say they've tried acetaminophen? What's the next recommendation?
Yes, and this is such an important topic, and you're right, we get asked this all the time, because obviously migraine is largely a female disease, and while we do know that for most pregnant women, luckily migraine tends to improve, especially after the first trimester, this isn't the case for everyone, and there's about 4 to 8% of women, depending on the study, where migraine either persists and doesn't improve or even worsens during pregnancy. So for these women, it's really difficult to find viable treatment options, and very often some healthcare providers are hesitant to prescribe medications during pregnancy because there's a lack of clinical trials in this population. But we do actually have good evidence on safety of certain medications that come from really large registries. And so for women who can't be managed with non-pharmacological approaches, which is obviously the ideal scenario, and who haven't responded to paracetamol, and actually I should add here, so paracetamol or acetaminophen, as you call it in your part of the world, but I want to note that there's actually recent evidence that raises concerns about this drug and potential links to urogenital and reproductive disorders in the offspring. So even this very widely used medication, we do have to use it with caution in pregnant women. But our recommendation is that if this drug fails, then we can definitely consider triptans. And we know that even if we use them with caution, there's really good data that suggests that they can be taken throughout all 3 trimesters of pregnancy, particularly sumatriptan. There's quite a lot of safety data, again, with registries of thousands of exposed infants showing no negative pregnancy-related outcomes. And then if nausea and vomiting are present, and obviously this is very often the case, metoclopramide can be added as a treatment. We should also say that generally NSAIDs should be avoided, but if they're absolutely necessary, say if a patient really only responds to them, then we should absolutely limit them to the second trimester.
So now let's move on to a healthy patient who is not pregnant, who has tried 2 different triptans. Let's say they've tried different formulation of triptans. What do you recommend then if those have not been effective for them?
So, if a patient fails two triptans, again, taken at the right dose and time and the appropriate way, in 2 out of 3 attacks, because we know that obviously migraine fluctuates even during the month, so there are some attacks that can be a bit more resistant to acute treatment. So, we do recommend trying at least 3 attacks. But if that fails, then they can try a third triptan. But of course, if that also fails, it's really time to consider a different drug class, like we were saying before. So, in this context, the recommendations really discuss the options of novel migraine specific drugs like lasmiditan, which is the only representative of the ditan 5-HT1F agonist drug, as well as GPANs, which are small molecule CGRP receptor antagonists. And actually, GPANs have a really significant advantage that they're not associated, at least up to now, with the evidence that we have, with medication overuse. And in fact, it's what's really revolutionary about GPANs is that also, Jessica, you know this very well since you've published a lot of this data, is that they can be used both acutely and preventively. And they've even been shown to have efficacy when they're taken during the migraine prodrome, so even before the actual pain phase starts. But of course, we know that unfortunately these drugs are not always available. So when they're not, we do also discuss the possibility of associating triptans and NSAIDs such as naproxen. There's really good data for sumatriptan and naproxen, for example, as well as, of course, with antiemetics, with which improve the efficacy of triptans.
So now we have an older individual coming into practice, someone who's around 70 and is still having migraine. And I have to say, I am seeing more and more of this. I thought when I started practice over a decade ago that all of my patients would be in their 20s to 40s. And now I'm starting to realize, yeah, that was not true. I have more and more people who have been aging alongside with me and are in their 60s and 70s and even 80s and 90s. And I definitely think it is a struggle to think about what to do for them for acute treatment, especially since cost starts to become a huge factor, approvals and medications become a huge factor, and limited data for this age group. So what are the guidelines recommendations here?
You bring such an important topic to the table. We have an aging population, so we have to really start considering these individuals and, of course, including them in the randomized controlled trials. And this is something that has been happening with the novel drugs. But in general, our recommendation for otherwise healthy individuals that are over 65-year-old and still have migraine with no known comorbidities that could alter drug metabolism, that acute treatment generally aligns with that of younger patients, but with a closer monitoring of potential side effects. So first-line treatment really includes acetaminophen and paracetamol, or even NSAIDs and aspirin that we can consider, but with increased caution. So we should pay particular attention to the risk of GI bleeding or renal and hepatic insufficiency. But also with patients who don't have any history of uncontrolled hypertension or cardiovascular or cerebral vascular disease, then triptans can be considered mostly as a third-line option. And in patients who either don't respond to triptans or have a contraindication to triptans, then we should consider either lasmiditan or GPANs because these drugs do not cause vasoconstriction. One thing that should be said about lasmiditan in the older population is that we need to be cautious about central nervous system side effects. So we need to really inform the patient on the possibility of drowsiness, dizziness, and fatigue, and the fact that they, for example, shouldn't drive for at least 8 hours after taking this medication.
So in our patients at Georgetown who are above 60, 65, we've been starting to do cardiac risk assessments prior to continuing or prior to starting a triptan. It's rare that we're starting a triptan after age 60, but every once in a while it might happen. Were there any recommendations in the guidelines about our 70-year-old patient who needs to continue on a triptan besides making sure they're medically stable or don't have comorbid disease, doing something like checking a cardiac risk score profile?
That's such an interesting topic. And I think these recommendations are a start and they're bound to change in the future. They won't stay the same as they are right now. So this is definitely something we can consider for future revisions of the recommendations because we don't have to say specifically mention a cardiac risk score in our recommendation, but definitely evaluating the cardiac risk can be useful. In general, what we say is that it's really important to assess factors that can increase the risk that is associated with vasoconstriction. So again, primarily uncontrolled hypertension or a history of stroke or cardiovascular events.
So let's move on to talk about the preventive part of these guidelines. So for prevention, what was the guidance given by IHS on when to consider starting prevention in a person with migraine?
The decision to start a preventive medication, as we know as headache specialists, is really a delicate moment. It needs to be patient centered and it needs to take multiple factors into account, right? So, our recommendations are quite broad, and we recommend to start a preventive treatment if one or more of these conditions are met. So, at least 4 or more monthly headache days, a significant impact on a personal, social, and professional life, or if we see that acute treatment is becoming ineffective, or if it's becoming too frequent. But we also say that prevention can be considered in specific cases, such as, for example, if there's frequent absences from work or school, and this is really important, for example, in our children and adolescent population, or if there's a substantial disruption in daily routine, but also if there's prolonged or severe auras. And finally, I think it's really important just simply for patient preference after carefully weighing the risks and benefit, because ultimately this decision needs to be tailored on the individual.
I think that's, really well said. I had a situation in clinical practice the other day that the fellow was presenting a case and the fellow wanted the patient to make a step to add in, and we're going to talk about layering treatments in a moment. And I asked the fellow, I said, I can see that you're frustrated, but the patient is not frustrated and the patient is satisfied. And sometimes we're here to support, but you have to ask the question, are you satisfied? Do you want more? And if they're satisfied and the answer is no, I do not want to do anything else, I want to stay this way right now, you have to wait. And I think sometimes it can be very frustrating as a clinician when you feel like there's so much more I could do for you. But if the patient isn't ready, it really is very patient driven. On the counter of that, if they're having infrequent attacks and they really want to start prevention and you're just a checkbox kind of clinician, and you say, no, you don't have 4 attacks, I can't do that yet, I think that's also very harmful. And listening, it's really the key to that relationship in practice. So another really interesting point, I think this is a little different in the US and globally, but I've always been intrigued about this, the global issue on how long to stay on prevention. So there's some really good key points in the guidelines about the length of staying on preventive treatment. Could you speak a little bit about that?
Yeah, absolutely. We also noticed, as these practice recommendations were really created by a broad group of physicians that practice in many different countries of the world, that we did tend to have different practices, and there's not that much good evidence on how long one should stay on prevention. So we decided to base it really on the route of administration, because we know, of course, that oral preventives require this really slow up titration to avoid side effects, and it can take between 4 to 6 weeks to reach the therapeutic dose and see the full effect. So we recommend continuing an oral preventive treatment for at least 6 months if it is effective to maintain that effect. On the other hand, with the injectable treatments, these are usually given monthly or quarterly. They do tend to show the benefits more quickly, but they have longer dosing intervals. So we decided to recommend to continue these drugs for at least 12 months. And a really special consideration needs to be made for Botox as well, for which we have extensive knowledge about. We've been using it for decades, mostly for chronic migraine, of course, following the very specific preempt protocol with the 31 injections every 12 weeks. But we know that some patients don't really see a response to Botox even after the first cycle. It can happen, but even after the second. So in these cases, we recommend to, for example, increase the dose to the maximum possible unit, which is 195, and continue for at least 3 full cycles before stopping.
I briefly mentioned this about combining or layering, and the practice guideline does discuss this. And I think this is really interesting for our neurology group listening that maybe does practice within headache or sees a lot of headache in their practice. So what if a person who has migraine is on a single preventive and isn't doing really well? When does this guideline recommend combining, as it calls it in the guidelines, but I like to call it layering treatment? When is this recommended? Is it for everybody or only those that have failed most of the first line preventives?
It's a very complicated topic. Again, there's a lot of variability in clinical practice. So, in general, our recommendation, particularly for oral treatments, is that monotherapy should be the goal because we have some evidence. It's not great evidence, but it has been shown that when tested in combination, the classic oral drugs like propranolol and topiramate or propranolol combined with amitriptyline don't really show heightened benefit and efficacy, but do show an increase in side effects or drug-drug interactions when taken together. But this principle doesn't necessarily apply to all drugs. So again, it needs to be patient-centered. And especially it doesn't apply necessarily to the injectable treatments. And specifically, there's high-quality emerging evidence that suggests that the anti-CGRP monoclonal antibodies, for example, could be more effective when they're combined with Botox. So this combination can definitely be considered in patients who have only a partial response to one of the two therapies.
I will say in the article, a really well laid out review of prior data where we do have lots of evidence about combinations of oral agents and how the combinations have not worked out so well. And again, side effects, really important that we consider this in already a very disabled population where we might be layering treatments that are extremely sedating, cause a lot of weight gain, really lower the patient's blood pressure, so makes them even more inactive at a certain point. And so key considerations here. And I really liked reading through, I thought a very well thought out, must have been very difficult to write because you have a very nice, varied group of authors, which I really appreciated. So you had lots of viewpoints. But I think the consensus that was reached was the really right mix of where to land on answering that. So moving on to what I thought was a really important question, because I think we're changing how we think about prevention in the space of migraine. A lot of that has to do with the newer therapies that we have. One of the questions was, should the choice of migraine preventive drugs be determined by the presence of comorbidities? And I think we've always had a habit of thinking, and I was trained this way, by co-treating disorders. Like if a person has hypertension and migraine, treat using an antihypertensive as the migraine preventive. But truthfully, it's not really the best way to treat either diseases. So what was the IHS's recommendation on this?
Yes, I completely agree. We were all, I think, trained that way. And possibly it's really interesting to see how we will be changing that approach. Because while the two birds with one stone approach seems really appealing, it's not really always the best strategy. So, for example, the hypertension example that you just gave, but also patients with migraine who also have depressive symptoms and for whom you might be trying amitriptyline, for example. Well, we need to remember that the dose required for the antidepressant effect of amitriptyline to start is much higher than the dose that we need for migraine prevention, and that is usually tolerated by our young female patients, for example. So it's not really as straightforward as it seems. And in this sense, the IHS recommendation is that migraine-specific treatments should be the first line of therapy. But that being said, it doesn't mean that we shouldn't consider the comorbidities. Of course, we need to consider our patients as a whole, especially if comorbidities can influence the efficacy of the treatment. So it's really important, for example, to account for drugs that can also worsen comorbid conditions such as, for example, flunarizine with Parkinson's disease or beta blockers in asthma, the really obvious ones. But in this sense, the recommendations have a really helpful table that outlines these interactions and provides some really good examples that can be easily remembered for clinicians.
All right, we're getting to the end. My last question for you. So I cannot let go of pregnancy. I think it's just such an important part of the treatment plan for our patients, especially since so many of them are in that age range. What were the recommendations for treatment in pregnancy and then during lactation for prevention?
As with acute treatment, our primary goal is to favor non-pharmacological treatments, such as nutraceuticals, peripheral nerve blocks, that don't have excellent evidence in general for migraine, but that can definitely be used in this population because we don't have enough studies. And also, of course, neuromodulation devices like the Nerivio or the TMS that have been even used in pregnant patients with no particular pregnancy-related adverse outcomes. But of course, these devices are not always possible or not always effective. So in the case that these kind of first line options are not viable, we recommend either propranolol or amitriptyline, after really balancing the risks and benefits and remembering that a very important propranolol needs to be discontinued in the last part of the third trimester to avoid adverse events on the newborns. And then there's also a mention of Botox for chronic migraine. There's not enough data to really recommend it as a first or even second line, but it can represent an option for the clinician after balancing risks and benefits, after having a very detailed conversation with the patient, because it does have a limited amount of systemic effects. And obviously, really important, we need to stress how important it is to avoid valproate and topiramate during pregnancy, but also just in general in the fertile years. If there isn't a strong contraceptive in place, because there's so clear teratogenic effects. And also a drug that we use quite a lot, candesartan, needs to be avoided during pregnancy, but it can be used again during breastfeeding, where the primary recommendation would be to either have non-pharmacological treatments or propranolol and amitriptyline.
So Francesca, anything else that you wanted to share before we get to the very end here?
I think that this document hopefully provides some practical guidance on the treatment of migraine for people who are very experienced with it, but also all the way to really to primary care. It's a document that works for everyone and that can also be used almost as an instrument to advocate for better therapies, for better availability for migraine treatments, with that differentiation between the optimal and the essential guidelines.
Just to remind you all, we've been discussing the International Headache Society's global practice recommendations for the treatment of migraine, both acute and preventive. And if you're interested in reading more about this, the publications are available at Cephalalgia, both online and in print.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.